I'm Dr. Arnold Wheel, and I practice in Atlanta, Georgia, and I practice non-surgical orthopedics and also specialize in pain management. Today I'm going to be talking to you about medical documentation. What's in the medical records and what does it all mean? So when we talk about documentation, what does that mean? Well, the written documentation of the medical encounter, that's really the key. The office visit, the surgical procedure, and even the telephone encounter. If it's not documented, then it didn't happen. That's the old adage. So what we try to do as physicians is document everything that occurs in the actual medical record. Now, it's really not always easy, not always practical, and we do our best to try to make sure that everything is in there. So it's very important from a clinical perspective to document the components of our evaluation and examination. We start off with a history. We take a very thorough history from the patient, and in this history we try to find out what the main complaint is. I like to ask my patients, they're coming to see me for the first time, if they could get two things out of this visit, what are they really looking to accomplish? But we take a very good history of what happened with the injury, what occurred, how did it happen, when did it occur, what brought it on, what types of treatments have they had, what's made it worse, what's made it better, what physicians have they gone to see, what other practitioners have they treated with. All right? So the history is very important. Also focusing on past medical history, chief complaint, other things I'll talk about in a few moments. The physical exam is the second component of our clinical assessment and documentation. We do a very thorough physical exam, but then we need to document that in the medical record. Our assessment, what do we think is going on, what's our diagnoses, and I like to try to convey to you, whoever's reading my report, exactly what I was thinking. What options and things were I considering? What diagnoses were I considering during my assessment phase of the exam? And then finally, my treatment plan. What's my treatment plan now? What may I consider in the future? And what things may determine what approach I take to treatment? So what components are important from a non-clinical perspective as far as documentation? Well, from a medical perspective, reimbursement. Obviously, I need to document everything that I'm doing so I can get adequate reimbursement for the time that I spent with the patient. And finally, there's a legal documentation perspective. Again, for protection of the patient and protection of myself, to document what I'm doing, what I've done, what my thought processes was, to validate my coding, to validate my assessment, to validate a particular diagnostic test that I may be wanting to do, and to validate my treatment approach. So what actually occurs in a typical medical encounter? Well, first, history of the injury, and I've already talked a little bit about that history of the injury, but it's important to document as much as you can about the injury and its history. Sometimes we are required, or we have the opportunity to review medical records. Either the patient brings these in, or these were sent to us beforehand from a third-party entity. And again, reviewing the medical records can be very helpful to get additional insight into the history of the injury. A lot of times, the medical records provide information that the patient doesn't always volunteer to us. In addition to the history of the injury and reviewing the medical records, we review the past medical history. Again, what other events have occurred in our patient's life that may be pertinent? Okay, do they have past medical problems? Have they had past surgical problems? Again, the past medical history, again, may give us an insight into the current problems and diagnoses. Finally, review of systems, what other complaints or symptoms may they have, and then the physical exam. These are all typically documented in the medical records, and they're based upon our medical encounter with the patient. So the goal of this encounter then is to assess the patient, establish our treatment plan, and support the treatment plan with the records. So let me give you an example of a typical medical report. I have a patient come in, and I'm going to document all the following in this report. Chief complaint. Why are they there? My low back hurts. I hurt my back. Okay. What is the course of events that led up to that? So I'm going to document not only they have low back pain, but how the back pain occur, when did it occur, what types of things did they notice at the time of the injury, did they go to the emergency room, were they evaluated by another physician, okay? What's happened since it occurred? If it was, a week ago, what's transpired over the past several days? Have they had other symptoms? Has it gotten better? Has it gotten worse? Again, all this is part of the chief complaint. And what I need to know and what I need to document in my report is everything that's occurred from the initial injury to the point that I'm seeing that individual patient. Okay? Often by taking a very good history, in particular the chief complaint and history of the present illness, you get all the information you need to help with your assessment and subsequent treatment plan. Past medical history, another component of the medical report important to document. Again, previous history of back pain, using the same example. Have they had episodes of back injuries or back complaints in the past? If so, did that have sciatica or leg pain with it? If so, have they had other injuries or other disorders associated with it? But the past medical history is important because sometimes we may learn things that may help guide our diagnoses. For an example, if a patient's had multiple infections or multiple episodes of back pain and there's associated weight loss with that history, it may make you consider or think about malignant lesions like a cancer that could be also contributing to the back pain. Okay. Social history, another aspect of our medical report that's very, very important to document. For example, smoking history, alcohol history, illicit drug use. These are all things that are important, especially when we're talking about patients with chronic back pain. We really want to get a very thorough social history. But I like to find out about patients' work history, about their family history. Are they married with children? What other types of interactions they have, what types of hobbies they have, what they like to do. Again, if I'm seeing somebody with back pain and I know they particularly like to play golf, one of my treatment goals then is going to be not only get rid of their back pain, but maybe allow them to go back and play golf again in the future. So social history is very important also. But a history of present illness is very helpful in order to determine if there are other entities going on that may not have been considered. For example, I see a lot of patients that come in and their complaints is pain in their back and other parts of their body. And they tell me right away, doctor, I have fibromyalgia. I've been diagnosed with fibromyalgia in the past. Well, I immediately like to take a step back and really take a thorough history, in particular history of present illness. Because I know that, for example, fibromyalgia is certainly a significant and very debilitating medical disorder. Fibromyalgia, though, it kind of tends to be a wastebasket diagnosis. There are certain criteria, specific criteria for fibromyalgia. Having trigger points, painful trigger points in 11 specific areas of documented trigger points. Okay? Having a lot of other complaints associated with their pain, sleep disturbance. Okay? There's some psychosocial components that go along with that, overlying depression. Okay? But what happens is a lot of patients see their primary care physician, they get told, oh, they have fibromyalgia, and all their complaints are attributed to fibromyalgia. Well, I like to take a step back and look because they may have fibromyalgia. It's a very debilitating disorder, but often I see patients given that diagnosis when they don't really have it. But even if they do have fibromyalgia patients can still have back pain, herniated disc, neck pain, elbow contusions. So I don't necessarily want to treat just a diagnosis of fibromyalgia, but I try to treat what the actual injury or actual problem is. So that's an example where you take a very good current history and a thorough history, and you may find yourself going along a different path and not just treating, in this case, fibromyalgia, but treating something a lot more specific like lumbosacral muscle spasm or intervertebral disc herniation. Then review of systems. Again, we go through a whole lengthy process with our patients. Okay, numbness or tingling, do you have problems sleeping, problems urinating? In fact, there's a checklist we like to utilize with probably over 50 different options as far as what other things bother them. We want to really assess every body system, the gastrourinary system, we want to assess the GI system, the musculoskeletal, neurologic, and pretty much question whether they have symptoms in every particular body system. Not to make it too lengthy of an exam, but again, to make sure we're not missing anything that might be important. For example, one of the routine questions is, any loss of bowel or bladder control? Obviously, that's very important. If the patient says yes, they have loss of bowel or bladder control, and they're coming to us with neck or back pain, that makes us step back and say, wow, this might be a lot more significant. Is it a cauda-equina syndrome? Is it something causing significant cord compression that we need to take more immediate action with? All right. So there again, review of systems is very important. Now, the physical exam is really the next step in our process. And again, we've documented everything up to now. We've documented chief complaint, we've documented past medical history, social history, HPI, review of systems, and now we do the physical exam. Again, you've probably seen many examples of records that have very poorly documented physical exam. How do you know that doctor looked at the lumbar spine? How do you know that physician actually looked at the patient's reflexes? All right? So the physical exam then encompasses pretty much from head to toe, or if you're assessing a particular body part, a targeted detailed exam over that body part. So if it's the knee, it should be the visual inspection of the knee, the palpation of the knee, range of motion of the knee, stability of the knee, and the integrity of the knee structures. All right? So again, but not just to do this part of the exam, but to document it. So if my patient sees another physician the physician can see what I did and what my physical exam showed. And that can be very important for down the road when we're making other considerations or other determinations whether our patient may require surgery, additional treatment, or what's been done in the past, even validating particular treatment. An example may be a patient that comes in and on physical exam, we find they have diminished reflexes, they have a positive straight leg raise test. Obviously, that documentation is going to support consideration of a lumbar epidural steroid injection at some point, more so than if there was no documentation there, no documentation that I examined the patient, and no documentation of any abnormalities on exam. So the next part of the medical report then is going to include the assessment. Again, I've seen the patient, I've obtained all the information, I've documented that, I've done my physical exam, I've documented that. What does that lead me to believe is going on? What is my actual assessment of my patient? All right. So again, the documentation there I like to stress is my differential diagnoses, what I think is going on, contributing to the different symptoms and complaints of the patient. Okay? And I try to start with the most specific and work my way down. And again, addressing the actual disorders that I see, whether it's intervertebral disc displacement, sciatica, muscle spasm, lower limb pain. Okay? Those are 4 diagnoses right there that I've documented in my assessment plan. Then if there are other comorbidities that are occurring, if it's a chronic pain patient and they have a chronic problem, is there obesity? Is there insomnia, which is because of the chronic pain? Those are additional diagnoses that should be documented in my assessment. Because if I'm going to provide medications like sleep aids, or if I'm going to provide other medications that address anxiety, for example, I should document in my report that I even included these as part of my assessment. And then finally, treatment plan. Treatment plan is really the end result of our visit. It's what we're going to do to help with our patient, address their pain, address their problem, address their disorder. And again, you should be able to look at the treatment plan and understand how the physician came to that particular plan. Why I want to use an anti-inflammatory. Why I want to send my patient to physical therapy. Why I'm considering doing an epidural steroid injection. Because I've documented above what happened to the patient, what kind of treatment they've already had, how it affects other parts of their life, what was present on my physical exam, and wow, what I was thinking was the diagnoses. Okay, it's all evident in my documentation in my medical report, and therefore supports and substantiates my treatment plan. All right, so those are the keys to documenting within the medical records. So how do you read the report? Well, today many physicians use electronic medical records, which is certainly very, very helpful. Okay? Electronic medical records allow for very, very good documentation. So you can look for the current status. What's the current chief complaint? Look for the initial complaint. Okay? Again, looking for the assessment and treatment plan. These are all present in the electronic medical records. And it's something you should be looking for if you're an adjuster or case manager, or if you're assessing this patient. So you should be looking at all these particular areas when you're evaluating the medical record from the rendering provider. In fact, you should even be able to look at the report and see who the rendering provider was. It's very helpful. I do a lot of review of medical records, and electronic medical records have made it, in some instances, much easier for me to look at a more logical approach to the current status of the patient, the initial complaint, and how we got from initial complaint to the current status. And again, supporting the assessment treatment plan, but certainly I should be able to look and see who the rendering provider is. Well, what if it's not electronic medical records? What if it's a handwritten note? Good luck, because too many times I've tried to decipher chicken scratch on records that make no sense to me. So again, I think it's important to gravitate more toward either a dictated or a electronic medical record in order to document your findings, document your thought process, and document your treatment. So what to look for? If you're looking at the records, if you're looking at the medical documentation, what should you be looking for? What's going to help you determine the next step in the treatment plan? Well, certainly the date of the office encounter is important. Every documentation should include the date. Not necessarily the time, but you should be able to look at it from a chronological standpoint when this encounter occurred. Okay? The notes should actually coincide with the diagnostic codes, both ICD-9 and CPT codes. And that should be supported from the medical records themselves. And again, the rendering provider should be available on that medical documentation. Now, I've talked a lot about office reports, evaluations in the office. What about operative reports? A little different, not quite so comprehensive as the patient follow-up and new patient reports, but nonetheless, still very specific. Operative reports should include preoperative diagnoses and a postoperative diagnosis, again, to support and delineate the type of surgery that's been performed. So in addition to the diagnoses, both pre and postoperatively, certainly the type of procedure, the procedure performed, the date, that should all be available and present on the operative report. And then finally, the physician or surgeon performing the operation should be available as well. Oftentimes, in our operative reports, we're very thorough in to provide a step-by-step report of the occurrences during the actual procedure. So again, what happened from the beginning of the procedure all the way through the end of the procedure back to the recovery room. Operative reports can be surgical procedures, can be non-surgical operative reports such as interventional spine injection procedures, epidurals, facet injections, discography, things of that nature. But again, the premise is the same. Document what you see, document what you've done, and document that everything turned out as it should. Now, there's another type of evaluation that I like to focus on, what's known as the independent medical evaluation. Independent medical evaluation is a type of evaluation that a physician may be asked to do that requires a more extensive evaluation than just taking a history and a physical exam from the patient. What is an IME? Well, an IME, independent medical evaluation, is looking at the entire scope of treatment, looking at all the records that are available for that physician to review from other providers, okay, and reviewing all these records. All right. Then